Well, thank you for all attending today. We've got some talks by myself on the MS Register and COVID, and we've got Professor Marco Salvetti from Sapienza in Rome, who's going to talk to us about the Italian MS Register and the Italian experience. And of course, you've got Professor Gavin Giovannoni, who's going to give us a unique take on some case histories and take us through those to try and help us manage today's world, I think. Shall I start? So I'm going to talk to just briefly about what we're doing in the UK. Obviously, we've had quite an experience the last few weeks as I've been working in medicine, as some of you have been doing, still working in medicine. Really, I'm going to talk about this, the impact of the disease-modifying treatments, the big question that we have in MS during the early phase of the pandemic. This data is, I'm presenting on behalf of our team and the MS Society and the MS Register. My disclosures, and I'm a member of the HTA, a NICE committee, so against all treatments generally. So really the question that we have in MS is that there's multiple disease-modifying treatments with a range of actions which are becoming really, we're favouring maybe increasingly immunosuppressant approaches. And we don't really know how that impacts people with MS in the terms of COVID. Guidelines have been come out. I mean, guidelines have come out from the UK, in Italy. They've rapidly come out, but they're really based on expert opinion and not on data. And one of the problems with the data is a lot of the data we get comes from hospital admissions, which may give us a slightly distorted view of the impact of this illness, not just in MS, but in many, many conditions. And also we have to sort of consider the fact that the risk of infection is changing rapidly in this period, not only from our own actions, but from government actions and patient actions. And also another issue that we have is the diagnosis of COVID. The idea of a positive test is ideal, but the question is what's the type of test that's important. So the PCR test is very accurate, possibly. However, it's only positive just from recent data from the Nature showing from only day 3 to 8, and then it's positive from day 5 to 15, but it's not replicating at that point. And the antibodies develop at day 7 onwards. So that's a real problem. And when do we test people and whether they've had the illness? And for the UK in particular, hopefully Marco will give us some views on Italy, is who actually gets the test, who gets a clinical review that's appropriate. And there's different approaches in different countries. So the aim that we started was to determine if disease-modifying treatments basically increase the risk of COVID-19 or enhance its impact in people with MS. So this was a study that actually was started on the 17th of March. So luckily we had ethics already in place for the UK MS Register, but we registered on clinicaltrials.gov as soon as we could as a sub-study, and that is still running. The MS Register is an online resource which records patient-reported outcomes and has about 18,000 people, and it works with the NHS, with 49 clinical centres to generate confirmed data that we find. And so we are able to check stuff up that we see on the register in the NHS and vice versa. So this is just, on the right is the participant flow. We basically emailed 17,000 people on the 17th of March and then did a lot of advertising and publicity to try and get some more people on, and they got about 500 people joined. Ended up with about 3,910 complete questionnaires. The question then came is who's got COVID or not. We had a self-diagnosed category, which is a 237, healthcare professional confirmed, which is 40, and confirmed by the lab test, which is 37. So this is as of the 23rd of April. So this is an ongoing study. So this is really are symptoms that we've seen. So the problem with the symptom complexes that we're seeing in this condition, and Gavin was just talking about this, is that it's really still being understood. So the gastroelectrical presentation, skin presentation, the COVID foot, and also obviously in children, it's still evolving what we're seeing with this illness. So this really it's some data that's coming out probably the next couple of weeks or so from the whole of the UK of 16,000 shows that there are different patterns of illness. So the problem is we asked a questionnaire on the 17th of March. We then added to that questionnaire on the 8th of April. And of course, now the questionnaire is maybe not completely relevant. really what we did is we took people who were self-diagnosed, people who said they had it, and this is the symptoms that they had. You can see they had high temperatures, about 26%. And basically, we then took healthcare professional diagnosed and then the WHO diagnosis. So a WHO diagnosis means you have to have a high temperature with some kind of cough or breathing problems or chest tightness. So it's sort of slightly separately defined. We actually confirmed the self-diagnosed cases by contacting about 21 people we contacted or gave us permission to be contacted, and all were confirmed as healthcare professional at that point. So we felt that we would go with self-diagnosed COVID at the moment as our best interim measure of COVID illness. One of the things that's notable on the right is that the people who have the WHO diagnosis, actually, it's a bit difficult, sorry to show it all in here, but they have more symptoms. So they have a more intense pattern of symptoms, more frequent symptoms, and more of the symptoms. So in a sense, they may have a more severe illness. And at the end of the day, I mean, does it really matter if they have had COVID if it's not going to cause you any problems? So the more severe illness is more important. So this is the story in the UK, and I think that'll be different elsewhere, which as we went through this, though this was a study just of the first month, already we can see quite a big difference. So the lockdown in the UK was announced on the 24th of March, and you can see that our numbers who are self-isolating essentially doubled to about 60% as soon as that was announced. But however, we can also see that the infections also increased from the third week, so 2 weeks after. And what we're seeing actually is things are still evolving in this population as we move through. So this is up to the 5th week, which is about when we stopped collecting this data. So we're in a moving situation. And so this is our populations and how they were. Now, I think it's obviously all populations are biased. So on the right, the left is the UK MS register population, which has its own bias. And then we see our COVID population, and then the people who are self-diagnosed, healthcare professional, confirmed, and WHO. And we see that basically people look younger in this population. We also see, maybe unsurprisingly, the people who are in this population compared to the normal UK MS register population, there's more relapsing MS. Again, we see their disease duration is shorter, again, not unexpectedly, and actually large numbers. So only 23% in the normal population of the UK register are taking disease-modifying treatments, but it's up to about 50% or so or more in this group about it. Our EDSS range is actually quite high, which we're still looking into because this is a web EDSS, so it has its own issues and it wasn't completed by everybody. So the thing is, this is an ongoing study, so people are completing questionnaires every 2 weeks, and this is just the baseline data. And one of the advantages of the trial design, well, we think, is that because it's linked with the NHS, we'll be able to go back and confirm what happens to our patients. Exceptionally, basically from the 17th of March to the 23rd of April, out of 3,903 people were admitted to hospital and all were recovered. However, one has to bear in mind that if you were in hospital, you may not fill out a questionnaire, so it's a little bit difficult just at this moment to take too much from it. But again, if you look at the self-diagnosis, 1.3% were admitted and all were discharged safely. So a good view of it at this point, and this is the problem with the hospital admissions, which, I mean, we're also collecting hospital admissions, which do look much more severe. So this is the treatments that they were on. Again, I haven't really done anything. That we have a large number of treatments. Some of them are in good numbers with dimethyl fumarate, ocrelizumab, and natalizumab. Cladribine, we've got about 71, 91 of Antrada. But there's no real trends that we can see, no significant trends that we can see, negative effects or positive effects about it in that group. So we're still, the numbers now, though we've got 3,900, we're now at about 4,700 patients. So the numbers have probably changed more at this point. So then what we did is trying to look for what's associated with COVID. Again, this is a sort of a multivariate analysis. And what we do see is younger age was associated with having a COVID infection. We hypothesized it might be there still, people are still at work, we have got data on whether people are still active or working, and it didn't really fit with that, but it does seem to be persistent through all the diagnosis. We also showed that having a progressive diagnosis was associated with less risk of having COVID, and self-isolation was associated with having a low risk of having COVID. So how we defined self-isolation was that people should have been self-isolating or isolated from people for 2 weeks before they signed up. So therefore, 14 days beforehand, they weren't in contact. So that was associated with a lower risk of having COVID infection. Disease-modifying treatment only in one. Obviously, as you see, we can got 4 different diagnoses. Taking disease-modifying treatments was again associated with actually a lower risk of treatment again, but this is just very early data about it. So really, in conclusions at this point, treatments that we have at this point don't seem to be related to an increased risk of infection. It does seem to be a younger age was associated with a higher risk of infection, and progressive MS and being self-isolated for 2 weeks was associated with a lower risk of infection. How we diagnose COVID-19 remains an issue, which hopefully we'll resolve as we go down. I mean, this is an ongoing study. We've just shared our data with MSIF to get a whole global view of this. And we're actually starting to look at the psychology, and we're going to be collecting blood samples from these people over the next month or so, as I say, as we evolve through this situation. So I'd actually just like to thank Fak actually on the right, who's actually done most of this from Nottingham with the Nottingham team and the Swansea team, and Emma from the MS Society. So thank you.
So thanks for this kind invitation. I'm happy to be able to share our data and experience here in Italy. These are my disclosures. So the data I will present today are part of a broader initiative of the Italian Neurological Society and the Italian MS Society. This initiative is a program that wants to be an answer to this unprecedented event. So apart from the objectives of this study that I'm going to present, which was an emergency for us as for others, we are also trying to answer some more long-term questions and problems, like the impact of this pandemic on psychiatric comorbidities, such as depression and anxiety, on patient-physician relationship, and on the development of new models of care. So this is just part of the whole program. So what are the objectives of this study? Our short-term objective is to see whether there is any evidence of a higher or lower risk to get the infection according to the treatment that is being used. In the long run, we would like to understand the risk factors for more severe outcomes and evaluate whether or not MS is a risk factor per se, because there are some immunological theories that may imply that both immune suppression and hyperactivation of immune system are both quite similar. They may look different, but they are failures of the immune response both. So it's not unusual to see that, for example, there is autoimmunity in immunodepressed patients and also infections in patients with autoimmune diseases. So we worked on a web-based platform that was dedicated to this study, and that is collecting data from centers in Italy and in other parts of the world. It's open access, so all participating clinical centers can ask for access to this electronic platform. We start from patients reporting COVID-like symptoms to their neurologist. And then this can lead to management from home or to admission to the hospital. Then in both cases, demographic data, comorbidities, and other clinical information collected, and then you get the swab, of course. If positive, then you go on and try to acquire some more information, particularly from those who are hospitalized. If it is not done, you collect information as much as possible all the same, and we follow through these CRF patients until the end of the infection. I forgot to mention that the follow-up is a weekly follow-up done by the referring neurologist. So these are just 3 slides. We can go quickly through them just to show you the electronic CRF. Okay, and these are what we had yesterday. Okay, so these are quite new data. We have collected information from almost 800 patients from 86 Italian centers and other 37 centers from abroad. The collaboration of the Italian centers is quite a long tradition. We are very lucky in our country to have a big network and a big tradition of collaboration among the patients. Though this email that is in Italian, I don't know, I don't remember if Gavin reads and understands Italian, but I will translate it because it's interesting, because when we sent the emails to all the centers, when we sent the email to all the centers to ask for a collaboration and showed them the CRF, we were in the worst possible moment in Italy, particularly in northern Italy. And so the answers we got in the first 24 hours from our email, this is just a sample, and translated is, I'm sorry to answer in such a rude way, but I have the impression that some of you do not clearly understand what's going on here in northern Italy. So at the beginning, it was not easy. Okay, and actually we thought very well before sending these proposals around, because we were, of course, very much involved by what was going on. So it is not true that we were not realizing what was going on. But anyway, we tried. And this really paid, because following the initial shock, we began to receive a lot of collaboration, and this continued up to now, and this is what allowed us to collect so much information. So you see here the distribution of the patients in the Italian territory. This slide is not regarding the 770 patients up to yesterday. It's a little bit an older slide. It deals with 570 patients, but anyway, the distribution is there. And you see that in Milan, Brescia, Bergamo, we have the majority of the patients. And also we have quite some patients from Turkey also. And these are the data that I think you may know that we published, being conscious that this was not an information that can be taken as definitive, but our decision to try to publish was driven by the need to inform people that there was no emergency, okay? And you see that at the time, the distribution of treatments in patients with suspected or positive infection, meaning suspected is patient reporting symptoms from home compatible with COVID infection, and positive are patients with a positive swab. Okay, so there was no signal of danger from the therapies, and I added a column to the table of the publication with some updated results on 546 patients, and you see that even increasing the number of subjects, the percentages do not seem to change significantly. And these are the data about persons with multiple sclerosis that died. You see that out of 7, 4 were secondary progressive persons with no disease-modifying therapy. Most of them had comorbidities, the comorbidities that we know are associated with the worst outcomes in COVID-19 infection. Also, the age range is in the 60s or 70s with one exception. So, what do we want to do when we will reach a sample size that will allow us to provide definitive answers? I'm sorry, no, what are the challenges we are facing now? Well, in the short term, it's difficult to see whether, for example, some excess of people in ocrelizumab, for example, we are observing is true, or it depends, for example, on the fact that more aggressive drugs are monitored more intensively, and this we will have to, of course, be sure about. And the sample, as you saw in the previous slide, is not representative of the Italian MS population, because the northern centers were hit in a tougher way. So the distribution in the Italian territory is really dishomogeneous. Challenges in the longer term are the definition of outcome, because we have to somehow resort to composite outcomes, and this may bring some problems, and also biases about reporting. You may have seen that apart from a slight increase in ocrelizumab treated patients, there is a slight decrease in interferon treated patients. If confirmed, this could be in line with what appeared in the Lancet a couple of days ago about possible efficacy of treatments that of polytherapies that encompass interferon beta treatments. Actually, there had been already trials with interferon beta in SARS already. Okay. That's it.
Thank you, Marco. That's really very interesting. Good to hear it up to date. Someone said, do you think that the low rate of events that I've reported allow you to draw inferences about the outcome of COVID infection in DM-treated MSs, or too few? I mean, I think the view, the numbers are still too small. And I think, similar to what Mark is seeing, we need more events. Thankfully, certainly in London, my experience of COVID has rapidly improved from an extremely bad position. However, the last week or so, there has been more patients admitted to our hospital, so I don't know what will happen. But I do think it's really a bit too early to say absolutely, but it's good that independent data sets are showing the same picture, which is a generally good picture about it.
Yes, I could not, the signal was not perfect when Richard was speaking. Anyway, I agree that with the last consideration that it's very important to have the opportunity to replicate data. Because if we are going to give some messages, we must be aware that there are many potential biases. The one that I mentioned about treatments that are more aggressive, and so there could be some reporting bias. This is very important, and this is just one of the reasons why we need replication studies. And also, we really do not quite understand, I think, completely the biology of the SARS-CoV-2. Because there is some, in Italy, it's really incredible, the difference that we observed in terms of incidence from northern country to from northern regions to regions in central Italy and in southern Italy. I mean, the life habits are not so much different between Rome and Milan, for example, but really the incidence was incredibly different. And also the time it is taking to go down in Milan, it really differs from what is happening and has happened in other parts of the country.
Richard, could I make a comment? And just going outside of the MS space, if you go to the rheumatology and the solid organ transplant space, the data from those groups also is looking extremely reassuring in terms of immune modulators, immunosuppressive therapies there. You're not seeing a massive increase in mortality in those patients, except actually for the ATG, the antithymocyte globulin treated renal transplant patients. And I think it's probably because they are much more T-cell depleted, those patients. And I suspect you need some T-cells to fight this virus. But, the anti-TNFs and the JAK inhibitors. So I actually think that the overall picture should be a positive one. We're not seeing an obvious signal. I think we've got enough patients if there was going to be a signal with immunosuppression or moderate immunosuppression, we would have seen it amongst these patients. And I think we could be pretty reassured that we're not putting our patients at increased risk of severe COVID-19 by treating their MS.
Can I just ask Marco about the access to testing? Because I think one of our, doing this study, obviously we've chosen patients within the community primarily, and very few are really access to a healthcare professional. I mean, that's the way the UK has been, and has that been easier in Italy, getting to see a healthcare professional and getting a test done? Is that easier? I mean, how many have generally the population been tested?
Again, this is very dishomogeneous among different regions. At the beginning in Lombardy, they were incredibly doing very few testing compared to Veneto, for example. And in fact, in spite of the fact that these were both both regions had a high incidence at the beginning, in Veneto, the numbers went down much more rapidly. And it's also perhaps a difference about the healthcare system there, because in Lombardy it's very centered on big hospitals, high quality hospitals, while in Veneto, for example, there is a lot of well conducted medicine in the territory. So that appeared to work quite well. And yes, anyway, there are huge differences.
Yeah. I mean, coming back to Gavin, I mean, in my center, we do have a large renal transplant population and hematology population. So they're just running some of the tocilizumab studies, both part of the national initiative and also locally about it, and modeling the illness that we see that can benefit from an immunological attack as being this sort of CAR T-cell reaction, almost this cytokine storm generated. Do you think any other candidates, people on MS, Gavin, you might be beneficial?
Yeah, so I mean, it's been my experience looking at the data that the natalizumab patients seem to be doing extremely well. And as you're probably aware, natalizumab does despite people not knowing this, most people don't, it does reduce trafficking of lymphocytes into the lung slightly. Not a lot, but it does. And Biogen actually did have an asthma program initially, which they aborted when the PML risk emerged. So, you could, and there's a fingolimod trial going on in China in terms of trying to treat their ARDS. So you could actually argue that there's like this little U-shaped thing. You want to get yourself into that little window where you've got some immunosuppression in terms of preventing the cytokine storm, but you don't want too much because you've got to obviously deal with the virus. And so I think this question will be answered, but I wouldn't say we're actually putting our patients at a lower risk of getting severe COVID-19 by giving them treatment. But I wouldn't be surprised if it does pan out that people on mild immunosuppressives actually do okay. I think the message we should go out there. We have to treat MS because this pandemic is not going to disappear in 3 months. Looks like with the flattening of the curve and the tail going out, we're going to be here in 2 years' time with this virus. The idea that we can put on MS treatment on hold for 2 years is ridiculous.
And Marco, did you put treatment on hold at all, or has that did the pandemic actually affect your services, your MS services, in different parts of Italy?
No, I would say no, because we were able to manage through telemedicine or phone calls. So I must say that for many neurologists, for example, in Italy, it's quite common that patients have your cell phone numbers, so your mobile.
Okay, yeah.
They have been calling, and with WhatsApp and these kind of things, we could manage quite well. And concerning treatments, after the 2-3 weeks of crisis where we let's see what happens, then now we are starting new treatments and continuing treatments, I would say, as usual.
Yeah, I mean, I think our experience in London was that we spent about a 2-3 week period that we were worried we'd be able to continue intravenous treatments, but then it just switched off like a tap almost, and seemed to be much calmer. Did you have any issues, Gavin, in your area?
No, I mean we had a difference of opinion in our centre because I just continued dose. I took the decision based on the mode of action of the drugs, that some of them would be safe. So we continued to dose. I mean, we couldn't give it. We stopped dosing alemtuzumab. We postponed that simply because of the logistics. We moved our infusion unit into the dental school, and we had to share it with dermatology, rheumatology, and inflammatory bowel disease, and so we didn't have much capacity. So you couldn't really take up you couldn't really do alemtuzumab, and we also stopped the HSCT, which is, I mean, Ben stopped putting patients forward or delayed the HSCT. I think there's a safety reason. If you did get COVID-19 after having your T cells flattened, the chances are you're going to die from the virus. You know what I mean? So I think there was a safety issue with those two drugs. But otherwise, it went on. We've had delays, unfortunately. The delays are around service, in the sense that, we just didn't have the throughput like we normally have, because one of our nurses was redeployed to the wards. Patients weren't able to get through. So we've had some consequences. I just did a blog post today on 3 relapses that I think are related to delayed in getting onto treatment. One patient was furloughed and went to live with her mother out of London, and so we were delaying her start until she got back. She's had a big relapse. That's, these are the consequences that would not have happened if we didn't have COVID-19.
Yeah, no, I mean, I think we saw that, but also patients were unwilling to come in, actually, to be assessed. And I think we saw in general in medicine, the whole of admissions cut down. So everyone was avoiding the hospital, which I think did result in some relapses, definitely. I think we have some more questions. Shall I look at them? Yeah. Someone said, do you think the younger age of patients with COVID is a reflection of the type of people who respond to the surveys? Well, I mean, you can see that the people who did respond to our survey is lower. And I think it may be that they're also more computer savvy. So I think, as I say, how to take that younger age, it's a bit difficult. We're trying, I mean, we in the register have got quite a lot of data that we can look at where people are from and look at their sort of deprivation, a number of indices we can look at. Nothing's jumped out, but we haven't actually done that yet. And also the lower rate of infection, the progressive group. Well, I think looking at the ABN to Alistair Cole's, this idea, some of the mortality seems to relate to increased frailty, which is what we see in general with the condition. I think it might be that the progressive group may be not getting out as much. That is what we wondered, whether they're... So we're still trying to figure out how to manage how long you've been isolating for and what sort of isolation. I think, I'm not sure about Italy, but certainly in the UK, it's suddenly coming to the fore as what shielding means for a patient and whether they should shield, because shielding gives you some benefits in terms of getting food delivered, and it may help you stay off work and keep safer during this period. So it's an evolving picture. So our problem is we started the survey very early on when we maybe didn't quite clearly ask what shielding was, what self-isolation was. So I'm not sure the progressive group is a particular indicator. Maybe it's just an artifact about it. And then it's asked, thus far, with the data thus far seen in patients on DMT, should we now revert to our previous practice pre-COVID regarding DMTs, except HSCT and alemtuzumab? Marco, what do you think? Did you hear that?
I would say that in most cases, yes. There are uncertainties anyway for the future. As you said, and Gavin said, we don't know what will happen in December. And also we don't know what will happen with vaccines.
Yeah.
This is an issue that maybe we can discuss. And this has to be taken into account. So I think that some caution, when possible, some caution we should try to exert it anyway. But being cautious, that does not mean that we have to deprive patients of effective treatments. It means that we have to discuss with them and try, we always have more than one single option. And in two options, there is always one that may be a little bit more appropriate than the other in this particular situation.
Thank you. And someone's also asking the Italian data, out of the 7 patients who died, any idea of their ethnicity amongst the patients?
No, we saw no differences. Perhaps we didn't have the numbers also.
Yeah.
Yeah.
This is one maybe for Gavin, really. For people who are due to have their year 2 cladribine course, should we delay? And if so, how long?
We're not delaying. We're going ahead with the course simply because with cladribine, the level of T-cell lymphopenia after dosing, with it would delay. It's like, with the scheduled, if you only dose after they get back to 800, the chance of getting a grade 3 or 4 lymphopenia now is less than 5%. So we're going to go ahead and dose, and we're going to warn patients that there is a small risk of them having a grade 3 or 4 lymphopenia. But even then, I'm not even sure that's too much of a risk, because I don't know if you're aware, there was this case at Queen's Square that had COVID 2 weeks after alemtuzumab, when they had no lymphocytes or very low lymphocytes, and they recovered without a problem. So I think, what is a safe lymphocyte count? If it's a young person without comorbidities, cladribine normally drops the total lymphocyte count to around about 700 on average, 600 to 700, which I think is sufficient. We're going to warn these patients to try and, be extra vigilant about distancing and hygiene and that. But we're going to go ahead and treat. We made a decision internally to start treating. And I think hopefully when the ABN review their guidelines, they may also take into account that. Cladribine is not alemtuzumab. It's nowhere in the same ballpark as alemtuzumab when it comes to T-cell depletion. We should be treating it more like an anti-CD20, to be honest with you. I would advise going ahead and treating.
So an anonymous attendee said, unless the ABN guidelines change, smaller centres will not start using ocrelizumab, and we need the ABN to respond and change the guidelines before we can resume ocrelizumab or cladribine. I can answer that one because I know that they're in the process of changing them as we talk. And Alistair's had 2 meetings, and I think certainly has the view that we can start going forward. We can't just sit here forever about it. And again, what was that? Are we going to change our treatment decisions after the COVID pandemic? A long-term impact.
Marco did refer to it. The issue is if a vaccine does become available, and we think maybe one will become available, there's so many goddamn vaccines in development. You may want to think about, what treatment will leave somebody vaccine ready if they haven't had COVID-19, and that will affect decision making. So there are certain treatments like the S1P modulators, potentially anti-CD20 that means you're not going to respond to vaccines. And the question is, will it be a live vaccine? So there are certain therapies you wouldn't want to give a live vaccine to. And the reason why I say that is the Oxford vaccine, for example, is using a viral vector. It's using the chimpanzee adenovirus to express the immunogen. So these kind of questions are coming up, but I don't know if we should really be crossing that bridge, because the vaccine's only going to be with us probably in 18 months' time. Marco, is it affecting your decision making, vaccine readiness?
Yes, perhaps to some extent, yes, because we always say, as you just said, that vaccines will come in 18 months. But who knows? This is an unprecedented effort by many research centers to achieve an effective vaccination. So we may perhaps find ourselves, I know that it's unlikely, but we may perhaps find ourselves in a situation where at the beginning of 2021, there is something available, and perhaps there is a resurgence of the epidemics, and you have the possibility to vaccinate, for example, the fragile patients. And it could be a pity if you cannot vaccinate, or the vaccine will not be effective in these people because they are in some disease-modifying treatment or another. So it's really, I'm not perhaps thinking too much about it now, but perhaps I will think a lot about it in September, October.
Yeah, I was part of the group recruiting for the Oxford trial, and again, the comments were that essentially that the vaccine's been tested in people from 18 to 50, 55, essentially with no comorbidities and no other illnesses. So at the end of the day, we're going to end up with a vaccine for young, healthy people who don't get the illness. And the concern is how well is it going to work in old people with comorbidities who traditionally the flu vaccine has never worked that well in. So I think there's, and the barriers that we have to get that vaccine. I think when I was doing it, I think there were 4 groups. There's Italy and China and US were doing other trials, had started, and 62 other groups were starting vaccine approaches. There was another approach at Imperial, which is using a different type of idea for approaching it. So I'm not sure how long it will take for us to get a vaccine about it, which is, I think, one of the concerns about missing treatment for me, about modifying what I do at this point. But, and when we started, I don't know, when we started interferon, when I started giving interferon in 1999, we used to say, well, you don't know how this would affect your ability to have another treatment at that point. So, not an easy question to answer, I think. And another question we've had is, do you consider changing monitoring patients during the pandemic, and which DNTs could be monitored less frequently, MRI and blood samples? Certainly in the UK, the ABN have recommended less frequent monitoring. And actually the question they have is whether patients will want to go back to more frequent monitoring. I don't know, Gavin, have you got any thoughts on the monitoring side of things?
Yes, I mean, the one that always worries us the most is the natalizumab patients, because you're picking up, potentially life-threatening autoimmune diseases. So, we've set up a home phlebotomy service with Bernie Porter's NeuroResponse for that, and we've continued to monitor on a monthly basis. I think some of the other monitoring requirements are probably unnecessary. Once you've been on, say, DMF for a year and your lymphocyte counts are on low, you probably don't need to do it every 3 to 6 months, which is some people do. And similarly, once you established on teriflunomide and you pass the at-risk period, the requirement to do the blood test every 2 months it's a European Medicine Agency requirement, I think is overkill. So we probably could modify these things and do them relatively safely. And hopefully when we come out of this, we'll actually say, because it's in the European Medicine Agency label, it doesn't mean to say we should be doing that. We should probably be generating our own safety data and modifying our protocols. Also, similarly, if you've been on fingolimod for 2 years and your lymphocyte count is, say, in the region of 600 and has been like that for 2 years, do you really need to monitor the lymphocyte count every 6 months? Can't you get away with it once a year? I don't know.
Yeah. So another question that maybe Marco, you might think of that. So young patient, JCV positive with aggressive disease, 3 attacks in the last 6 months, all recovered partially with steroids and Plex. Do you recommend cladribine? Put you on the spot. You know what happens. So.
I don't. Why? Yes, cladribine could be an option. There are also other options, I think. Again, as I said, cladribine has many advantages. The only disadvantage I see is the long-term action in this uncertain situation for the future. That's really the only problem I see. Otherwise, it would be really an ideal treatment, really.
I mean that patient, I would say, why don't they put them on natalizumab as a bridge? Even though they're JC positive, you can start them on natalizumab and keep them on for at least 6 to 24 months with the extended interval dosing, and the risk of PML is manageable, and then switch them later on when you've got some more certainty. That's what I would do with that patient. I put them on natalizumab, even though they were JC positive.
Yes, I agree.
Yeah, no, and I would, we too, but we tend to use it in JC positives. But yeah, I'd agree, 24 months would give you a chance of breathing space, exactly. And I think one other, Gavin, how do we discuss the possible vaccine effect? How do we discuss the subtleties of vaccines with someone going on to ocrelizumab, what we should and shouldn't do?
Yes, so I think starting ocrelizumab is fine, and when the vaccine emerges, you probably can get away by delaying or stopping the next dose and allowing some B-cell reconstitution and then revaccinating them. Because I don't know if people have seen the phase 2 data, and with the rituximab experience as well. Once you've had 3 or 4 courses, in other words, 18 months of treatment, even if you stop the therapy, the disease activity doesn't come back for a long time. So I think you could probably stop the treatment, wait for B-cell reconstitution, have the vaccine, which will give you a better chance to respond to that vaccine. That's what I would do. I wouldn't switch treatments in anticipation of a vaccine. Wait for the vaccine to emerge. Switch. What people don't understand is in the current environment, while we're still in lockdown and we don't have a face-to-face service running, the logistics of changing treatment now is quite difficult. You've got to do baseline bloods. You've got to bring people up, and you've got to counsel them. So, I wouldn't recommend changing treatments in the current environment. Just continue as is, and then cross the vaccine bridge when it seems to be emerging. Also, I don't know if I suspect if a vaccine is shown to be effective and it gets launched, I'd be interested to know which groups get access to it first. It'd probably be high risk older patients will get it first. I'd be interested to know if MS patients or people with autoimmune disease will be prioritized as high risk and get access to the vaccine first. But I'd be surprised if the general population get access to the vaccine first, because it's going to be a limited supply. The whole world will want this vaccine. They're going to need billions of doses.
Another question. What about combination therapy for people with MS, interferons and other disease-modifying treatments during COVID. Marco, have you feelings on that?
I think I am a fan of combination therapies. I think, particularly for progressive MS, but I think this is really an uncharted territory during very dangerous times. So I would not take any risk about combining therapies at this stage.
Yeah. Thanks. Maybe we should move on to Gavin's presentation with some of the cases that he's going to give us.
Well, we probably could just do the one case because in terms of timing, so I'll do that. So this actually addresses some of the questions people have been asking. So this is just an example. It's kind of fictionalized, but it's based on some of the questions I've been sent in by people on my microsite. So this is a 28-year-old female solicitor with rapidly evolving severe MS. So she was actually treated first line with alemtuzumab in June last year. She presented in the December before with optic neuritis with poor recovery. She had a relapse with a spinal cord involvement in March with reasonable recovery, but you can see she's been left with disability. She had a very high lesion load with activity, gain-enhancing lesions. The diagnosis was pretty firm as being MS, and one of the reasons why she chose alemtuzumab is that she wanted to have her disease under control to start a family. All right, so she's due for her next dose next month of alemtuzumab, and the question then, maybe one of you could answer it. Would you go ahead with redosing with alemtuzumab, or would you let her wait? Richard, do you want to answer that question?
I mean, to say we would probably go ahead with redosing. I think it depends what the environment looks like in a month's time. If it continues to stay calm and improve, I think we've already started starting new dosing ocrelizumab. Our main problem with alemtuzumab is we haven't got so many people doing it, and it's the practical situation with the bed situation and getting people in is the biggest problem. So at the end of May, if it all goes according to plan, we would probably redose, but we would recommend self-isolation and ask that she would support her trying to maybe work from home. As I say, especially difficult with children.
She hasn't got kids yet. No, this lady hasn't got kids. So the question about self-isolation now is, I would check according to Alistair Cole's, the infection risk in terms of viral infections really almost disappears after the first 4 to 6 weeks. In the trial from the KMS1, KMS2, the viral infection risk in terms of CMV reactivation, the herpes viruses were really front-loaded in the first 4 to 6 weeks. And so by the time you get to 3 months, most of these patients weren't getting infections. But I would just check a lymphocyte count at 3 months, and if it was close to 500, she probably would just have to go on as normal. Yeah. That's what I would. Yeah. I wouldn't tell her to self-isolate for 6. It's impossible. I mean, people don't appreciate how difficult it is to self-isolate for any period of time. Yeah. Marco, would you redose, or would you tell her to go on to something else, or would you just let it wait?
Yes, I would say that given the present situation, I would say yes.
Yep. Yeah. So when it comes to point 3, yes, if in the UK now, the ABN guidelines have said during the COVID pandemic, switching to 3 monthly would be fine. I think the autoimmune risk is lower in this lady because she's still into year 1. As you're probably aware, the autoimmune risk really ramps up after year 3. It's usually around 18 months after the last course. If she was in our centre, she'd be having hers done monthly via our home monitoring service. So we would continue with the monthly monitoring if she was in our centre. But I suppose if you don't have the access to home monitoring, then you could use the ABN guidelines to do it 3 monthly. And here comes the vaccine question. What about a possible vaccine? Can she have this in the future? And I think the thing about alemtuzumab is once they reconstitute it, in terms of having a normal lymphocyte count, say even above 800, vaccines aren't contraindicated, and even live vaccines can be given. So once the immune system's back. So this is actually one of the agents that's probably useful to have, in the sense that if you are going to need a vaccine, you can have the vaccine. What about being able to fall pregnant in the future? I think no different to being outside of this environment. She can fall pregnant in the future as she wants if she's been treated properly. That comes up to a question. Somebody asked a question before the webinar started, Marco. Have you had any of the pregnant MS patients in Italy develop COVID-19?
No, actually we didn't. Not at all. As far as we know, nothing.
Richard, have you had any pregnant women register with COVID-19 on our register?
Yeah, we've had one, and she's been completely fine. So she was really minor illness. Just very anxious about it.
So what I'm going to suggest, Sarah, is we keep those case studies for the next webinar, because they're all very complicated and each take about 10 to 15 minutes to consider. So if people want, I know people ask for complex case studies, but we don't have to rush through them today because we run out of time. And there were some questions that came through before. Do you mind if I just finish those, Richard?
Oh, yeah.
One for you is about clinical trials. When do you think we can recommence clinical trials?
Well, it depends on the trial, but I think we should be starting, I would practically think we should be starting soon. I think, firstly, a lot of trials have been suspended that has caused a problem with those trials and may actually critically injure them if we aren't able to continue to treat people and monitor them. Obviously, we have to be done safely. We are involved in some phase 4 trials where people are getting treatments that are available on the NHS, which aren't available on trials, and that needs to get going. With the new treatments, I think the novel things, probably in about the next month or so, I would be thinking we're certainly pushing to start getting trials back up and running. I heard the one thing I did find, having taken part in the vaccine trial, is that they managed to get everything through so quickly. I couldn't believe how fast clinical trial regulation could work in a different situation. How much easier it would be in the normal world if it worked like that.
One thing that this has shown us is that when you're forced to do things differently and do them quickly, you can do it. It just shows you that the systems, the friction disappears. People then go out of their way to make things happen. I just wish we could take this from the COVID-19 pandemic. Our research office, everything just seems to the NHS. There's just no friction. You want to do something, go ahead and do it, and then cross it. Even when it comes to finance.
So we had someone who did the MERS and the swine flu epidemic in the UK. Peter Openshaw was telling us about it. That his there were 3 phases of the illness, and before he got permission, it was into the last phase. It was a year later before all the permissions were through to start monitoring it. Whereas this, actually, to be fair, in this situation, things have got going in the midst of the first peak. So, as you say, it can be done. Very good.
Well, anyway, so when it came to our setting up our home, the Bernie Porter set up with Neuroresponse, there was no time to get the contracts and the funding in place, and she was given the go-ahead from NHS England. Just go ahead and put the service in place, and we'll sort the finance out later. That never, ever happens in NHS, that you could actually set up a service before you've got the finance in place, because the finance, as you know, the contracts and everything, take months and years to sort out, and then you get business cases rejected. So this is actually common sense. Set up the service because it's needed, and we'll find a way to pay for it afterwards, which is remarkable.
Really, in the next 5 years, finding ways to withdraw the service, so which is what they tend to do. So,
yeah. I don't know Mark, I don't know if the same things happened in Italy. They allowed you to do things you would not normally allowed to do.
Yes, definitely.
Yeah.
Yeah.
I have to say that working together has been a thing that's really worked well in this epidemic. Having worked in medicine, worked across different specialities, it seems to be certainly the NHS. I don't know if it's the same in Italy. It seemed to the hospitals worked much better with the community, much better across almost all directions. When you took away these barriers, these artificial barriers between us, life seemed a lot more pleasant, actually, strangely enough, in the hospital. So,
yeah. Actually, there's just Richard. There's just 2 more questions coming. Maybe we should just deal with those before closing.
So do you have any comments on pediatric MS, considering we have less options to treat children with MS? And how about the safety of fingolimod in children with MS during the pandemic? Gavin, any thoughts on that?
I don't think we should treat them any differently to MS. My big query there, if you were talking about vaccine readiness, you probably don't want them on fingolimod. You'd want them on one of the other therapies. But fingolimod is the only one that's truly licensed in inverted commas. But I wouldn't treat pediatric MS any differently to what I would be treating adult MS and the way they've treated it before. Actually, they respond to the virus much better than adults.
Yeah. We had a patient with COVID symptoms who was on DMF with a lymphocyte count of 0.56, not tested for COVID. When I tried to add it to the MS registry, it appeared that it had to be confirmed COVID. I think that was a problem in the way it was written, which I think we've actually amended, because I had that question too. So we can add suspected patients. That's something that for our registry. Patient made a presumed complete recovery. So also after presumed COVID, do you suggest patients still need to isolate if lymphocytes remained low? Marco, any thoughts on that? No.
I mean, the antibody test will be available. I mean, we've just got the Abbott assay about to start running. We're just doing the pilot on the first 400 people. So, I mean, I would test her for the antibody. And if she has seroconverted, based on immunological principles, she's likely to be immune to reinfection. Actually, I don't know if you saw over the last 3 or 4 days, the South Koreans have withdrawn that paper, that data, saying that those patients that got reinfected after recovering from it was probably a false positive from the assay. They were all very, very low, very, very low viral levels, and they don't think they were true positives. So actually, that's the evidence that you can get reinfected is actually very poor. Based on those patients that came out, that data came out of South Korea. So I actually think, based on basic principles of immunology, if you've had a true COVID-19 infection and developed that cytotoxic CD8 and an antibody response, it's unlikely you're at risk of being reinfected. Would you agree with that, Marco?
Yes, the point is whether or not single persons will be able to mount neutralizing antibodies, because this is a cytopathic virus, and so it's an acute infection, and the immune system responds differently to cytopathic viruses compared to what the immune system does with non-cytopathic viruses. So the development of antibodies is faster, but may not last as long as for non-cytopathic viruses, where it takes longer, but then once you have a response, then you tend to maintain it. Also because you are always re-stimulated by the fact that the virus is there. So it's difficult to say. I don't want to be pessimistic about vaccines, but I guess that it will not be an easy virus to manage with immunizations, I think.
No, I think respiratory viruses have a long history of being very difficult to form vaccines for. So I'm actually quite skeptical. I think the chances of a successful vaccine are probably in the region of 50 to 60%. I think there's a good 40% chance we won't get an effective vaccine.
Yes, I think it will be easier to get some drugs or monoclonal. I think. Yeah.
I have to say, well, thank you to Marco and thank you to Gavin that's coming along and sharing your experiences. I think, certainly my experience of this pandemic has been a very interesting medical learning experience. I've never been in a pandemic before, and I think it's taught me something I never really thought I'd ever see. So almost a privilege to go through new medicine, I have to say, from my point of view. And obviously, as a doctor, learning about new illnesses is always interesting. I have to say, sorry to sound very cynical about it, but I don't know what you think. Marco, any thoughts?
Yes, I completely agree. Our clinical practice changed, perhaps not too much with MS, but more during our clinical practice with other neurological diseases, like stroke and all the other. The ward activity is the one that really changed a lot. And we focused much more on relevant and practical questions, less than we did before on some, more fancy hypotheses and so on. So we learned to be more effective, I would say.
And Gavin, any thoughts?
Well, I just think, I've never seen knowledge being, the generation of new knowledge and insights has been so turbocharged in any field in science. We've gone from zero to having all this information and actually disseminating it and adopting it and affecting our practice. Literally, it happens in days and weeks, and hopefully when we get out of this, we can actually continue to do that. I mean, I actually now look at the bioarchives first. This is a non-peer reviewed place, so the whole idea of adoption of ideas and knowledge is this is changing the way we acquire knowledge and usage. So it's very positive. And having webinars like this that Sarah runs with MS Academy is what the MS community is wanting. They like the fact that we get people like Marco coming on, you sharing stuff before it's published, insights from it are being adopted. People feel much more comfortable, changing their behavior on data that's not published, which is remarkable.
I think I have to say that I agree. I think that allows us to see, like we're not behind paywalls anymore where we can't see data. It takes a very long time, looked at by lots of people. Obviously, it may not be right. I think that those are really interesting, the archives. Exactly. It's changed my view of them completely. Absolutely.
I think it's going to become the norm.
Yeah, I think so. Yeah. And a better norm.
Yep. Yeah. Okay, good. Thanks, Marco. Thanks, Richard.